start?
Why don't you grab your food? I'll wait for you.
Okay. And I don't know if you wanted me to be the first My own experience I said, I don't mind talking about it.
Okay, good. Well then,
Let me just grab a plate.
okay.
She said, oh.
Yeah.
So, are you receiving email right now?
I was just making sure that Dr. Pulicharam signed.
Yes, well, so her assistant is trying to email you a large file, apparently.
Okay.
Like a new large file. She didn't tell you?
No, she's not.
Okay.
Because I can't see it. She's saying it's not going for whatever reason.
Okay.
Try to send it to Megan. You had the
When I receive it, but I'm also not getting
Oh, but you just ask her to send it to Megan.
yeah,
How are you?
if it comes.
Implementing and spreading within the choice systems, and then how do you get the systems to play together and make
Well, I've done a lot of work. Well, I'm my HR faculty every year. Then we've gone over but that was about 10 years ago.
It was Boston, almost ended up in Pulicharam, but that's really.
Well, it was a life-changing year. Because then I went back to the UK and did more and more research, did a lot of things. Actually, I was very lucky. And then I went back to the UK in my region, which is southwest of England. It just so happened, as soon as I got back, they partnered with tried to do a whole regional project with 5.5 million people. So I ran the ICU arm of that. And then I worked with them in Denmark and the Middle East, Singapore. And then lastly, before I left, I was on the assistant medical director for NHS England, so for quality and safety for 6 years.
It's just,
But recently, I mean,
we're kind of bunched up
my,
here and then
I'm an
we
anesthesiologist
can't
by
see each other.
background, so my interest is in social outcomes. And we've done some very big studies on improving outcomes from emergency surgery, and learned a lot. We did 2 really big studies in the UK, just had published one of them in the Lancet last week, a couple of weeks ago. But a lot of learning. Because as you say, the big one in the Lancet, we didn't really show a difference, and it was a 27-step pathway across 90 hospitals. And one of the issues is it had to be done as a wedge step plus a randomized control trial. So we couldn't bring the teams together to learn from each other. Whereas the other study that followed, which we did more of an IHI breakthrough series of 25 hospitals, and we brought them all together on a regular basis, and that showed improvements. But it was only 5 things. So I think there was a lot of learning between the 2 studies. You know, how you get people to change and being too ambitious. But the first one that was published in
So
Lancet
thank
was
you
more
everyone for being here,
Yeah.
for coming from the 4 winds. We've had some very long flights to get here and some very long flights that are about to be taken. Thank you, Dr. Aranguri in particular, for coming after a 9-hour flight to be with us on this incredibly important topic. So I have to just point out to you that we have some data that can inform what we're doing at your places. And some of that data I received from the California Office of Statewide Health Planning and Development just 2 weeks ago. And that is the up-to-date Office of Statewide Health Planning and Development hospitalization data for heart attacks and strokes. And what we found in that data is that statewide in California, there were approximately 300,000 hospitalizations for those 2 conditions, and about 1/3 of them, just under 100,000, were for people less than 65 years of age. So you will see in many of our materials the emphasis on thinking about the younger groups and their vulnerabilities. I didn't bring our full 31-page packet today, but the California Department of Public Health is printing a good deal of our materials that I'll bring next week. But I just want to thank all of you for the work that you do that's so important for keeping families together. And welcome back our co-chair, Carol Peden, who is going to tell us about some wonderful work that she was doing this weekend for this cause. But before we have the main speakers introduced, we want to have a patient perspective shared with us on this important topic of cardiac rehabilitation. So welcome Keith Emmons, the head of our heart failure work group.
Well, I can officially say good afternoon.
Yes.
No, come on.
Good.
Good afternoon. Hey,
Hey.
how do I look?
Great, amazing.
Huh? I look good? Yeah? You like that? Yeah? Right? All right. No, I just want to kind of be in front of the camera here. You know? Well, you know, I wasn't always this handsome and debonair. Just a few years ago, 2.5 to be exact, I could barely get out the chair and walk across the room. Yeah, I had heart failure. And so this topic of rehabilitation is very important because it was a end product of a disease that had been going on for about 25 years. And I was in some rehab, so I'm hoping we're going to hear about that. But I continued to deteriorate to the point where I did need a transplant. So I look so great now because of the transplant. But I'm still not able to do everything that I'd like to do. So I have continued post-transplant my rehabilitation. And I wanted to not tell you that about me, but about a patient. Because in the rehab I go to where I had the transplant, I don't know if I can say the name because we're Cesar's in Los Angeles. It's a wonderful program. I'm working to get them to come and talk about what they do, both pre-procedure and post-procedure, and I have tentatively penciled them in for October when we again, the heart failure subgroup has its meeting, has its presentation. But I was able through that program to meet a lot of different people. I mean, there were 20-somethings there, 20-something-year-olds there that maybe had some type of valve problem, congenital, or something like me, a little idiopathic, and or maybe viral or something where they led to heart failure. But there were people of all sorts of socioeconomic backgrounds too, all people, different racial backgrounds. And I was just talking with Dr. Alan Fremont here about knowledge is not enough. We know what to do. We all consider ourselves to be great communicators. And we can talk with a patient, and we can explain everything, and we may even explain it to them, maybe not in very technical terms about ejection fractions and stroke volumes, but maybe even in their own language. But still, somehow, we don't get through to everyone. Now, that's a frustration for me because what I see my calling now in life is to get to that population. How do we try and not only get our message out, or get our message out to people who say they understand, but then also will be motivated enough to do whatever change is necessary. It might be a change in their diet. It may be a change in their lifestyle. It may be whatever, I don't know, but that's what I'm looking forward to hearing. And so what I wanted to do in front of you this morning here is to say, not everyone you look at can you really judge them about what's happened to them in the past. And I've seen some successes, and I've seen some failures. And some people, I say failures, I'm talking about people that heart failure, that just, I don't know. I was talking with Alan here and saying I felt frustrated because they understood what I was saying. They understood they needed to change. They understood they needed to watch their salt intake, for example, as they're piling on the salt of the fried chicken. They just didn't want it. So how can we reach people to provide them with a better life? So that's what I'm looking forward to now. And I just wanted to present that as a way of saying, just when you look at someone and they, if you're talking to a patient, how can we reach out? What tools can we use to get over what I was calling the hidden barriers? Oh yes, I understand, doctor, but I'm not motivated enough to do it. So that's what I'm looking forward to. Thank you, welcome this morning, and I'll turn it back over to you, Candy.
Thank you, Dr. Evans, for that moving story. It's wonderful to have you as part of the team. We have a small but select group in an amazing session today, but Hattie asked me just to speak for a moment about what I was doing on Saturday night, which is relevant, you'll be glad to know. I was the co-chair of the American Heart Association Heart Ball, which was held in Los Angeles on Saturday night, sponsored by USC, which is how I came to be the co-chair. Interestingly, our survivor story was another physician, Dr. Howard, I don't know if you know each other, who's had a heart transplant, at USC, so that was the story. But the main theme of the program, of the fundraising, was for the American Heart Association's Gardening for Schools programs. The heart, to really focus on the socio-economic aspects of healthcare, to get children at schools growing plants, understanding where vegetables come from, running farmers markets for their communities. And USC is a big sponsor of this program in East Los Angeles. The program now runs across America, but it actually started in Los Angeles, in Inglewood, 10 years ago. And when you see the children, it's fantastic. If you ever get the opportunity, and if you wanted to go, let me know, to go to these schools in very, very poor, deprived areas and see the children being very enthusiastic about growing healthy food and vegetables. So, and the good thing was we raised $927,000 for that program. So it's another move in the right direction. So we have an incredibly interesting program today, and our first speaker is Dr. Alan Fremont, MD, PhD, on the power of more real-time population and individual cardiovascular and diabetes data, and the impact of the RightCare initiative pilot in San Diego. You have the CVs in front of you, so I won't read all of Dr. Fremont's amazing CV here, but safe to say he's the physician policy researcher and director of RAND Q-DART project, RAND Corporation member and a RightCare technical expert group and co-principal investigator. So with no further ado, Dr. Fremont.
Good afternoon and welcome. While Megan sets this up, okay, so the first, Keith, thank you for your sort of introduction to rehab and so forth. I'm going to talk about, not jump into rehab just yet. Hattie had asked me to share a little bit and just some highlights of some of the ways in which one of your cousins, in terms of the San Diego RightCare effort, how some of what they did around reducing cardiovascular risk and reducing heart attacks and strokes, is some of how it played out. And in particular, I'm going to highlight some studies that one was done independently, and then we did a follow-up. And as is sometimes very hard to do, and Carol can definitely attest to this, when you have collaboratives or regional efforts, it can be very hard to show impact, at least beyond the individual systems. And we did seem to show some impact. And so I want to highlight some of that. I'm going to just give you a few sort of slides and stuff to sort of give you some sense of what we did and how things evolved there. But really the purpose is to continue to plant seeds here and think about how in LA, whether in a single spot or in a particular region or a whole county, how might we move the needle? Okay, so let me share this. Okay, so I'm going to try to keep this short and go through a few things. So I left a few things out. But what you should know is, while we were having a lot of success in terms of having a meeting like this and having lots of different stakeholders participate, and then we had working groups like what we call the data group, doing stuff, and we were seeing some improvement in individual systems. We didn't necessarily know whether much was happening at the population level. And then a gentleman, Brent Fulton and Susan Ivey, who had done some work out of Berkeley, they had the rather scary notion of actually looking at San Diego data and from population and other stuff, and seeing if one of our principal aims of reducing heart attacks and strokes, whether there was any evidence that it really is making a difference. And to my surprise and their surprise and a lot of people's surprise, there was a big drop in the number and rate of heart attacks in that region compared to the rest of California. So what I'm going to highlight is we wanted to verify that and look at it in using similar but different methods, and also see if to the extent there was some impact, was it sustained? Because in addition to it being hard to sort of show some initial bump in local populations, it's hard to sustain that. And so that's what, so there's three basic questions. So over the time that the RightCare initiative and later called the Be There San Diego, what's the cumulative impact so far? And then has San Diego maintained the gains relative to the rest of California? And then were the changes uniform across groups? And we're just going to touch on those very briefly. I like suspense, but I'm going to cut to the chase, and then we're going to actually kind of look under the hood a little bit. So here's what we found. In terms of the impact and the savings, in San Diego, it was about 3,800 hospitalizations for acute myocardial infarction. That translated into about $86 million savings. If the rest of California had similar drops or similar changes in their rates over that time period, almost 42,000 heart attacks and nearly $1 billion in savings would have accrued. The money savings is impressive, but I want you guys to get present to and really get that 3,800 looks like, it's an impressive number, maybe not. But you're talking about not only all the cost of in the multiple hospitalizations or rehospitalizations that are important under value-based care now. But all the people in their immediate family, in the networks, in the places they're employed, and how much disruption it causes. So these are huge impacts. Okay. So what did that look like? Let me orient you to this slide. This is showing age-adjusted hospitalization rates for those who were hospitalized with acute myocardial infarction. And it's showing the rate per 100,000 residents. The periods we looked at was data from the state and hospital discharges from about 2007 all the way through 2016. There's some more recent data, but I haven't had a chance to analyze that. And then we divided this up into two different periods. There's the before, the pre, either San Diego, and then in the second one, there's the post period, which is, we call early post, which is about the period that the other paper had looked at. And then we had a later post, meaning from 2014 to 2016, after that first analysis was done. We want to see whether San Diego kept the lead. And kind of as you can see, there is around 2010, there was this big drop off in San Diego. The efforts of RightCare, the RightCare initiative in San Diego started about 2009, and then there were lots of meetings and symposiums and discussions of evidence, the best emerging evidence and what could be done. It eventually evolved into a university of best practices, and then later, as I'll show, there was some other things that started to happen, such as we set up a good data group that we wanted to monitor lots of stuff that was happening. We attracted grants, and I recommend you go to the Be There San Diego website and just look at sort of, from its early origins in something like, very much like this, it sort of blossomed. Okay, so what you see is around 2010, there's this inflection point, and there was a big drop-off. And not only was there a big drop-off through 2011, but it actually kept going down until about 2014. It was going down faster than the rate in the rest of the state. And then in the later post period, you see this inflection going up in San Diego, but you also notice in the top line, it also went up in the rest of the state. So there was something happening, but what it looks like is in the first part, the overall post period, San Diego was about 22%, had more of a change than a decrease in heart attack rates, compared to about 7.5–8% for the rest of California. If you just look in the additional period, the later post period, that same basic pattern was maintained, even though it started to things started to go up, and there was an inflection point up. It seems like huge changes, but the thing to understand is, we used what's called a difference in differences approach. You're not talking about a huge number of heart attacks in terms of, the difference in differences between the rest of the state and California. It was about, say, 28 in the later period and 26 per 100,000 residents. So it's a lot, but it was doable. Okay. We also looked, to the extent we could, in some of the different subgroups, and we're trying to figure out, well, you know, what kind of explained the original inflection, and then what about where it starts to go up. And the gist of this slide, and what you're looking at is, this is by age group, and on the lower part you can see the youngest group, 18 to 44, is to the left, and the middle group is 45 to 64, kind of working adults and so forth, and then 65 plus is the latter group. And one of the things we found was that across, or in San Diego at least, the drop was, you know, fairly uniform, or at least we're seen in all these different groups. If you go over to the right, in the later years when there seemed to be this, the whole state and actually throughout the country, we're starting to see some increase in heart attack hospitalizations. The San Diego maintained some of that decrease over the time period, whereas in the rest of the state, you know, they really mainly got their drop in the Medicare population, the 65 and over initially, and then in the younger group, in the later period, it starts to increase. And in fact, some of the CDC data was showing that the heart attack rate is increasing within that group. Okay, so Hattie had kindly provided a title. We didn't necessarily have real-time data for this particular analysis, but we had we had data that was, you know, within, say, 6 months or something like that. And this data was actually, comes from what the working group that we established a little bit later, where we had many providers and health plans that were sharing some of their data on quality metrics and so forth. And we basically combined that data to look at, you know, what was the collective improvements. And so one of the areas of focus was on hypertension, and kind of, as you can see, sort of it started out lower overall, around 71%, and then by 2014 and really over the next few years, the groups that were participating in the effort and in, you know, what's sort of a hybrid quality collaborative did improve, and it was the goal was around 80%, and you can see for the top line is diabetic blood pressure control, and the red line is for hypertension control. And so kind of the question is, what were they doing and how did we see these kinds of changes? And so let me just give you a little bit of taste of that. If you are curious, there's a paper in Health Affairs that goes into much more detail on this stuff. And that's that. Okay, so let me kind of rewind and say, so, you know, we're sitting here now and it's back around 2009, 2010, 2011. What sort of things were happening, and you know, to the extent that there was sort of evidence-based practices that weren't necessarily being used, and suddenly we had provider systems start to use it. What was that about? So one of the major things that happened in San Diego was we had evidence coming out of Cesar on just these pretty spectacular reductions in heart attacks, or in basically the risk for heart attacks, that can be achieved relatively easily by using not just one but a